Today we are talking all about medicines. Now, medicines are not a clear part of lifestyle medicine when it comes to helping people improve their diabetes, but it can be and is an important and integral part of many people's journey with type 2 diabetes. And for some people, type 2 diabetes cannot be fully controlled with lifestyle medicine approaches. That's nutrition, exercise, well-being, sleep and stress. It may be that it's just not possible to be fully successful with that approach. It may be not appropriate for certain people. It may not necessarily fit in with what people want to try and achieve, with all the things that they want to achieve in their lifestyle. And of course, medicines have been the forefront of type 2 diabetes management for many years, until recently when we've realized that we can do something about type 2 diabetes that doesn't require taking medicines every day. But they remain still very important for management. So I'm just going to talk through some medicines today, and what you'll find is that I'm saying lots of big words, and don't worry, I'll cut through all the big words and we'll just run through some common medicines. Hopefully you'll find it quite interesting and insightful whether or not you're taking medicines. Right, well, the first medicine we're talking about is something called metformin, which is also known as a biguanide. Now, metformin has different names, but that's the official drug name, and other names include glucophage or Staccato. And metformin primarily works by reducing liver glucose production, and it improves insulin sensitivity, especially in muscle tissue. It may also slightly reduce the absorption of glucose from the gut. Overall, it looks like it's got quite a few good mechanisms for helping us to improve our blood glucose control. Now, it was discovered really early on in comparison to some other newer medicines back in the 1920s from a plant, and then it was studied and then introduced in 1950s, and in the UK it was introduced in 1958. So really it's been the mainstay of diabetes management for a very long period, and I'm sure will continue to do so. Metformin is very effective, so that's why I think it's going to continue to be used quite a lot. It leads to an average HbA1c reduction in millimoles per mole, which is the UK EU way of reading diabetes management, of 11 to 22, which is roughly 1 to 2% when you look at the American Canadian units for reducing blood glucose. Now, there's lots of studies that have looked at metformin, and we know that it works really well, and we see it clinically in practice. We put people on metformin and they tend to reduce their blood glucose down really well. It does have some potential positive side effects, but the data is conflicting. We tend to think of metformin as a non-weight gain diabetes drug, which means that it doesn't cause weight gain, but in some studies it is suggested that it promotes weight loss. So it remains the first line medicine for clinicians in the UK, and I'm sure across the world it is the most commonly used metformin, and it's one of the most prescribed medicines in the NHS. Now, there are some potential side effects. Now, the one that I see most commonly is gastrointestinal side effects. Gut related IBS type side effects. Discomfort, sometimes a feeling of reflux, but most people don't get reflux from it. It's more like indigestion, and then some people can get diarrhea with it. And I have seen probably around one case a year, maybe two, a significant reaction with metformin. And the reason why I think I see it fairly often is because so many people are on metformin. But those reactions with metformin are not like anaphylaxis or severe allergy reactions. They tend to be insidious, and they tend to be related to the gut. And as soon as those medicines are stopped, then often symptoms really reduce down and go back to normal. People get side effects with it that are tolerable, but I think the small number that I'm mentioning here are the people that get really bad side effects to the point where they can't take this medicine. A lot of people who keep on a lower dose when they get side effects because they find that higher doses cause much more intolerable side effects, whereas they can tolerate some of the minor side effects at lower doses. And it is available in different ways. So you can take it as a modified release. Usually it's taken with meals. So for some people, they might take it twice a day, other people once a day. Typically speaking, most people take it with meals. Most people take it twice a day. You can take it with every single meal 3 times a day. You do have to be careful with metformin if you're unwell. And usually I recommend people to stop taking medicines if they feel unwell because of the risk of it impacting the kidneys. Actually really cheap medicine, and that's because it's off patent and it's very widely used and very cheap to produce. So it usually only costs in the NHS or to the patient £1 to £2 per month, but in the UK if you're type 2 diabetic, you get your medicines for free. So most people in the UK won't be paying for metformin. So it's a very cost-effective option too. But then there's a second most prescribed medicine in diabetes, especially in the UK, sulfonylureas. Now, names of medicines might include bencolamide, gliclazide, which is the most commonly used. They stimulate the pancreas to release more insulin. And when you've got more insulin, that stimulates the body to take the glucose and store it in cells, because that's what the insulin does. Now, it does that regardless of your blood glucose levels, which can be a bit of a risk. So for some people, if you've got low or very well controlled blood glucose levels and you take gliclazide, it can increase your risk of having a hypoglycemic attack, hypoglycemia, which is a very low blood glucose level. You just have to be very mindful of that. It is extremely effective. I'd say this is a medicine that we tend to use when people are quite poorly controlled and we want to get very, very good control of their glucose quickly. Then this is a very good option to use. The only thing with gliclazide though is it tends to contribute to weight gain in many people, and because of that we try to avoid its use where possible, because weight gain can actually worsen diabetes control in terms of the underlying reasons. So although we're treating you with a medicine that's going to help this, because it may be potentially not making the underlying reason worse, we probably want to try and avoid it where possible. But again, like I said, if we want to get really good quick control, then we would use this medicine. I'd say it's pretty safe medicine in terms of side effects, aside from low blood glucose level. So it's a very well tolerated medicine, probably less side effects that are reported compared to metformin. And typically speaking, you would take this with meals, especially because it can cause a low blood glucose. And some people, if they've got very good blood glucose control and they're taking this medicine, we wouldn't recommend that you then reduce the medicine. Wouldn't recommend that you take this medicine if you're missing a meal. So if you've got good control and you're taking gliclazide, it's possible that you could miss the medicine. Now, everything that I'm saying today doesn't replace your medical practitioner's advice, whether that's a diabetes nurse, medical doctor, or pharmacist. So these are things that you can think about, but if you have any ideas about your medicines and you want to try changing them based on what I've said, I would go and discuss this with a health practitioner first, person that knows your medical history and has been managing your diabetes. Now, the other good thing about gliclazide is that it's very cheap for public health systems, and if you're paying for your medicines, generally tends to be a lower cost medicine. So in the NHS, £1 to £3 per month, probably around $5 in the US in equivalence, but I'm not saying that it's $5 in the US. I know that medicine costs are very different depending on where you are in the world. And then remember that overall that's be under £40 per year. So it's actually very, very good medicine to use. Then we've got gliptins. So that is sitagliptin, saxagliptin, linagliptin, and these are called otherwise known as DPP4 inhibitors, and they're a different type of medicine, and they tend to be used a lot 10 years ago, and I think they're being used less now. They're very good because they've got a reduced amount of side effects, but in terms of their impact on blood glucose levels, probably not as good as the others. And what we tend to find in the long run, say after 4 or 5 years, what we tend to find is that they tend to be less effective. So when people are on these medicines for very long periods of time and they've got poor control, I really try and stop these medicines, because essentially I don't think it's actually doing anything for the body. They do have some very rare side effects, such as pancreatitis, but again, that's a very, very rare side effect that it's been linked to. And the thing about DPP4 inhibitors is that they are, so that's medicines like sitagliptin, Januvia, linagliptin, which is Tradjenta. They're very similar to GLP-1 injections that have been really commonly talked about recently. They essentially help to impact on that cycle in a different way, but much, much less significant in terms of the impact. So again, this is a medicine that I don't use too often with my patients, and if people have been on it for a long time and they don't have very good control, I'm often trying to stop this medicine. It's a little bit more expensive than the others because it's a relatively new medicine. So generally will cost around 30 to 40 pounds per month, or around 4 to 500 pounds annually in the NHS. So you can see there's suddenly a big difference there. Then we've got SGLT2 inhibitors. Now get ready for it. Sodium glucose cotransporter 2 inhibitors. Yeah, that's a big one. So we just stick with SGLT2. Even that's big enough, I think. So get ready for the names. These are awful. So empagliflozin, also known as Jardiance, dapagliflozin, also known as Forxiga, and canagliflozin, also known as Invokana. Now, in the UK, we don't use the brand names like Jardiance, Forxiga, and Invokana, so it becomes even more difficult to think about their names. But basically, the way that they work is they block this protein called SGLT2 in the kidneys, and this prevents glucose from being reabsorbed in the kidneys. So when the kidneys are filtering out waste, they actually filter out the glucose, and that glucose gets reabsorbed normally in the kidney, so we don't lose the energy, the glucose. But what this medicine does is it stops that reabsorption from taking place, which means that the glucose gets excreted in the kidneys, which means that we're peed out in the urine. Excellent, because now we've got less glucose in the bloodstream. Now, this one has been associated with potentially supporting weight loss, and it's had some other unintended positive effects. In the scientific community, they have studied it rigorously for other things, including heart-related problems, so all-cause adverse experiences related to heart problems. That includes heart failure is reduced when it comes to taking these medicines. So taking these medicines can also help to reduce the risk of heart failure, reduce the other potential impacts of heart effects, so that's including heart attacks, and also can slow down chronic kidney disease. So it's seen as renoprotective, cardiorenal protective, heart protective, and kidney protective. So I'd say pretty good medicine when we're thinking about trying to get good control of diabetes because of the other unintended benefits. It has a significant impact which tends to last, and it's pretty well tolerated. One of the key side effects is because you're causing more glucose to be excreted from the kidneys and then you're peeing out more glucose, is it makes us want to pee more. Now, when we think about how diabetes develops, one of the symptoms, if we catch it late, is finding that you need to pee more. And that's because glucose is so high in the bloodstream, the kidneys are getting rid of more of it naturally to try and lower down the blood glucose level, or it can't take enough up because there's too much glucose. So that's what essentially this medicine is doing. It's getting rid of the glucose in the bloodstream, and it's usually taken once a day in the morning, so it's really kind of easy to take as well, with not many side effects on the gut like the others. Now, the only thing is, because it's another relatively new medicine, it does cost the NHS public health a lot more, and if you've got insurance it might cost more. If you're paying for it, it's going to cost more, roughly 30 to 50 pounds a month, and that makes it around 400 to 600 pounds annually. So you can see that that's quite a lot. GLP-1s, now these have been really commonly discussed, thought about, wanted in the diabetes community, and now also in the weight loss community because of their impact. Now, the reason why these are particularly powerful medicines is not because of the very quick response in terms of blood glucose that they can provide with making people feel full and reducing appetite through the GLP-1 pathway, but because that then leads to an impact on the underlying reasons for developing type 2 diabetes, which can be related to too much fat within the body, especially visceral fat, which is fat around our organs. Because we've got reduced appetite, we're eating less, we're starting to lose weight. And then what that does is it increases the space for more glucose to be stored in our tissues, whether that's muscle, liver, or in the fat. So now we've got better control, not just by reducing appetite, but in the long run, by allowing more space for when we do eat for blood glucose to be stored. So a double effect, really. And that is why it's become such a popular medicine. It's seen as this new medicine that's going to help us with getting weight loss, but there are some potential major drawbacks with it. And with anything that looks amazing, there's usually something that's a bit of a difficulty with it. So very good chance of lowering your A1C really significantly by about 1 to 1.5%. That's 11 to 17 millimoles per mole in Europe. But there are common side effects, and side effects are expected with this medicine. So those side effects include nausea, feeling of fullness, which is basically how it works by reducing your want to eat more food, but it can also be worse than that with vomiting or more discomfort. Now, rarely it can cause something very serious like pancreatitis. Now, that is very, very rare. I haven't seen it in clinical practice, and I hope never to see it. But there is a potential risk of pancreatitis, which is where you would have severe tummy pain, and it would cause major problems for you in terms of symptoms, but also can be quite difficult to manage. So that's the big one that most people worry about. There is this association with thyroid cancer. It's a very loose association, but because of some concerns, it is recommended that if you have a history of thyroid cancer, you shouldn't take this medicine. So that's important to be mindful of. But if you have a history of other thyroid problems, for example, an underactive thyroid, that doesn't necessarily mean that you can't take this medicine. So the unintended positive side effect is the weight loss, which is what helps also not only from a metabolic perspective, but may also be helping from a cardiovascular perspective. Now, what I can't tell you right now is if the cardiovascular improvements is down to the weight loss or is down to a different mechanism with the medicines. Now, this is where different healthcare practitioners are talking more about, and I'm not going to go into detail in that today. It's probably something that I need to research in a bit more detail before I can start talking about that with you. Now, the difference with this medicine is the way that it's given. Typically, it's given by injection, but there are new methods of taking it by mouth. Interestingly, because it's being given by injection for a period of time, I think at the moment people prefer to take it by injection, which has surprised me really. But it's only a once a week injection rather than a once a day injection, which is what it used to be. And I think they're trying to build more formulations, for example, making it just once a month as well. Now, there is a potential risk with low blood glucose, but I think that's really only if you're taking it with the other medicines such as gliclazide. Now, this is an issue as well because of the cost. The cost is actually quite high. So in the US, it's much higher than in other countries, but in the UK, for example, it's roughly around £100 a month. So we're looking at about £1,200 annually. So that isn't cheap. And if you're taking a number of these medicines together, you can see how these can add up. Now, the final medicine, which people don't often associate with type 2 diabetes, but it is still something that many people are on, including my clients as well, is insulin. You might be thinking, well, why are type 2 diabetics on insulin? Well, over a period of time, the other medicines become less and less effective. And that's where insulin comes in, because insulin is always a safety net. Directly giving insulin to the body means that the insulin can work directly on any glucose that's coming in. Now, there's different types of insulin, and insulin is complicated. So you've got rapid acting ones which work within minutes to bring the blood glucose down quickly. Then you've got short acting, which is slightly less quick than rapid acting, but that will go within your meals. Then you may have twice daily insulin, which you take twice a day. And then generally speaking, you're going to get an intermediate action where the insulin is going to work between 6 to 12 hours. And then you might get mixes of rapid acting insulin and intermediate to longer acting, which is what you might take with a meal. And then you know that there's still going to be an amount of insulin available in the body. And then you may have very long acting insulin such as Lantus, or also known as Glargine, which you would take once a day or once in the evening, and it would just help to keep a baseline level of insulin so you don't get too high with your blood glucose. There is always a risk of very low blood glucose. If you take too much insulin, then you are going to force your blood glucose down. It is a life-saving medicine for type 1 diabetes, and is ultimately a life-saving medicine for type 2 diabetes when the other medicines are not effective. And it can reduce glucose levels significantly, but it is related to the dose. And the higher the dose, the higher the chance of weight gain, which is a bit of an issue for many people. And that's because the insulin basically is a storage hormone. It basically pulls that glucose to be stored into fat cells. And you can get injection site reactions, which are unpleasant, and many people don't want to be injecting insulin regularly. Pretty safe with kidneys compared to other medicines, so that's often another reason why you might use insulin. And in terms of the cost, so it still remains a relatively high cost because of the way it's produced, despite having been around a long time. So it may still be sort of upwards of £1,000 plus per year, but most of the time it will probably be a bit less than that, and that's in the UK. Now I just want to illustrate how different these medicines are in terms of cost. So in north central London, which is around a fifth of London in terms of catchment area, has around 2.2 million people living there, and there's a 6.7% diabetes prevalence rate in this area of London. So I'm assuming, based on 6.7% of 2.2 million, that's roughly around 147,500 patients with type 2 diabetes in this part of London. And I remember in the UK, in the NHS, medicines costs are covered by the NHS. And so I did an estimation on roughly how many patients might be on different medicines, and I looked at the costs of them. So if people were just on metformin and glycoside, which are the medicines that have been around for a very long time, glycoside has the risk of a very low blood glucose levels, but they're both very, very effective in terms of blood glucose control. Well, in the UK, roughly, per year, cost of metformin is £38 and glycoside is £32. That's really low compared to, per year, the cost of a GLP-1 is roughly £1,221. DPP-4s, which are the ones that I don't think are that effective, including sitagliptin and linagliptin, are £357. And then the ones that help you pee out glucose, the SGLT2 inhibitors, £473 per year. And you can see how high these costs go. In terms of prescribing costs, we have roughly many patients will be on metformin and glycoside, and around, I've estimated roughly 32,000 patients will be on the higher cost medicines. But the cost of the higher cost medicines in north central London is £17 million in 2022. The cost of the lower cost medicines comes to around £2.5 million, and many, many more patients will be on them too. So it just goes to show, as we ramp up medicine support for patients with type 2 diabetes, the costs significantly increase. Yet you might be surprised to hear those costs are probably offset by the prevention costs that they enable. But still, if we were to take in more lifestyle medicine approaches and support those patients who are having higher medicine costs, then we could potentially not only improve their health, make them feel better, but also support lowering costs as well. Now, that approach may have already been tried for many patients. The medicines that they're on may be the most appropriate despite maximum lifestyle medicine interventions. But my experience working on the ground is that those patients have limited support. They basically do not have any support for any programs to help them to get their lifestyle in check. Yes, there's other options available to them, including weight loss medicines combined with the injections, but often we're not going down to the root cause of supporting these patients. But overall, I hope you can see that medicines are an important part of diabetes control, and I support anyone who is taking medicines. I prescribe medicines. Try to look to the root cause of the illness as well as taking your medicines, and some medicines will support the root cause a little bit better and more effectively than others. And we've got to be mindful that all medicines do come with the risk of side effects. Well, I hope you've enjoyed that talk today, and I'll check in with you all soon.